Greetings everyone, and welcome back to another academic half day. Today I'm going to give you a brief overview of head injuries and the consequences of intracranial hypertension. So the topics we're going to cover today, we'll start with a general overview of the basic physiology of the metabolism of cerebral circulation, as well as the autoregulation that occurs in the brain under normal conditions. Then I'll give you a quick overview of a variety of different primary brain injuries that can occur, including the epidural hematoma, subdural, traumatic subarachnoid hemorrhages, the intracerebral contusions and hematomas, and then finally a discussion about the diffuse axonal injury. Then we're going to dive right into the problem of secondary brain injury, which relates mostly to the issues of increased intracranial pressure, the consequences it has on the compliance in the Monroe-Kelly doctrine and its implications. Give you a lot more detail about how the response to injury has impact on both the metabolism and the circulation of the brain and its overall response to the neuronal response to injury. And then close off with a more detailed discussion about the management of intracranial hypertension, both from a surgical and a medical aspect. But to start, before we can get into too much detail about injury, we need to first understand how the brain metabolizes energy. Now, the brain is unique in that it is the only organ that relies almost exclusively on glucose as its sole substrate for energy production. And only under very rare and extreme circumstances can it use ketones as an alternative fuel source. When we talk about energy consumption and metabolism in the brain, there are two phrases that you're going to hear very frequently. First is the cerebral metabolic rate for oxygen and the cerebral metabolic rate of glucose. Now these terms sound similar, but they're actually different because in general they're closely matched. The amount of oxygen consumed is usually fairly closely related to the amount of glucose consumed. And sometimes they're considered interchangeable, but there are circumstances where we'll make the distinction between the two of them. In an awake adult, the cerebral metabolic rate of oxygen consumption is about 3.3 milligrams of oxygen per 100 grams of brain tissue per minute, whereas the cerebral metabolic rate of glucose consumption is 5.5 milligrams of glucose for every 100 grams of brain tissue per minute. Now, of all of the energy generated in the brain, 50% of it is actually used for the interneuronal communication, generation and release and uptake of neurotransmitters, and that type of activity, which, as you can imagine, is very metabolically demanding, would require a lot of energy. Another 25% is used for the maintenance and the restoration of ionic gradients across the cell membrane, which again is very important as part of action potentials. And then the remaining 25% is then usually used in the other day-to-day housekeeping items of cellular metabolism, such as molecular transport, biosynthesis, and a variety of other different processes, which we're not going to really concern ourselves with. Now, obviously, most of the energy generated is consumed by the neurons. These are the most busiest cells in the brain. Glial cells, while they make up over 50% of the brain, have a much lower metabolic rate. And as you probably recall, glial cells largely provide a lot of the sheathing and protection and coatings, and therefore really don't require as much energy as the neurons, which are doing all of the heavy lifting. The glial cells themselves, despite their large number of them, actually have such a low metabolic rate that they only account for about less than 10% of the total cerebral energy expenditure. And interestingly, the brain is actually a huge energy hog. It accounts for only about 2 to 3% of our total body weight, doesn't actually do any physical mechanical work whatsoever, and yet it has to receive and consumes over 20% of our cardiac output and the energy that it delivers. So the brain is a real big energy hog, and speaking as one brain to another, damn important, I might add. Now, obviously, in order to survive, you need to have a continuous supply of glucose. Your brain has developed a variety of different mechanisms in order to defend itself against the loss of its blood supply, which would result in the death of not only of the brain, which doesn't have the ability to regenerate in quick fashion, but also would result in the death of the organism as well. So there are many different systems that have been put in place to defend blood flow and provide and ensure that there is a constant cerebral blood flow to provide a continuous oxygen and glucose delivery. Now, the amount of substrates that are available to be delivered and consumed by the brain are determined by several factors. Number one, the actual concentration of the substance in the blood. Number two, the flow volume through the blood vessels that can be then delivered to the brain. And number three, the rate of the substrate passage across the actual blood-brain barrier, which is largely determined by the diffusion ratio. Now, usually the brain is able to maintain a more than adequate supply of substrates, and it does this by regulating the cerebral blood flow. The cerebral blood flow is adjusted by controlling the vessel diameter, and this is what we refer to as autoregulation of blood flow. Now, depending on the circumstances, there are a variety of different mechanisms that are in place that help regulate the blood flow and control autoregulation. Now, if you've heard about autoregulation before, you're likely familiar with this type of diagram. This is a diagram that graphs the cerebral blood flow rate against the cerebral perfusion pressure, which is the ICP subtracted from the mean arterial pressure. And as you can see on the yellow line that for a very wide range of cerebral perfusion pressures, the cerebral blood flow is constant. And the way that's maintained is by varying the size of the cerebral vessels themselves in order to maintain a continuous, a constant flow rate despite the changes in the pressure. When you get to the extremes of low perfusion pressures or high perfusion pressures, then you start to see changes in the cerebral blood flow. And when the cerebral perfusion pressure is low, you start to see the blood flow drop off until it crosses a threshold called the ischemic threshold, and brain injury or secondary injury starts to occur. On the opposite side, on the right-hand side, you can see that after the cerebral perfusion pressure reaches a certain maximum, any increases in the cerebral perfusion pressure beyond that overcome the brain's ability to auto-regulate and control the vessel size, and you start to see an increase in the cerebral blood flow as a result. Now, one of the consequences of brain injury is that it changes both the location of the curve and also the shape of the curve, and it can take a variety of different configurations. But for the purposes of this diagram, you can see that the brain in a brain injured person, the relationship between the blood flow and the cerebral perfusion pressure becomes a linear relationship, and there's a for every change in perfusion pressure, there's a change in cerebral blood flow. This would be an extreme example where autoregulation is completely lost, and now the brain is completely dependent on the cerebral perfusion pressure to maintain an adequate and safe amount of blood flow for oxygen and glucose delivery, and to keep the brain above the ischemic threshold, which, as you can see, in the injured brain, the ischemic threshold is actually shifted. Because the curve is shifted to the right, ischemia can occur at a higher perfusion pressure. So now the first mechanism of autoregulation that we're going to discuss is metabolic autoregulation. Cerebral blood flow is tightly coupled to the cerebral metabolic rate and changes proportionally with increases or decreases regional or global metabolic needs. Now 95% of the oxygen, of the energy in the normal brain is generated by oxidative metabolism, and so the cerebral metabolic rate of oxygen is considered to be a very sensitive measure of cerebral metabolism overall. So in general, the brain then responds to alterations in its metabolic rate and its metabolic demands by changing the flow, and thus has the tendency to keep the arteriovenous oxygen delivery relatively constant. So what this means in general is in areas of the brain where there is a higher amount of demand, such as, say, for example, right now in my speech centers, where it's very active, there is an increase in blood flow because of the increased metabolic demand. So that the amount of, even though there's a higher oxygen consumption going on in that portion of the brain, because of the amount of oxygen that's being delivered, the amount of oxygen that gets out onto the venous side is unchanged because of the increased delivery in that area. Alternatively, in other portions of my brain, which are not very active right now, because I'm just sitting here recording this for you, such as the motor strip, that area of the brain is receiving, because it's not as metabolically active, it's receiving a lower blood flow, or is demanding a lower blood flow. And so even though it's receiving a lower blood flow, the amount of oxygen that's being, the amount of oxygen that's being extracted is maintained and kept constant. Now, pressure autoregulation is what we often will refer to when we talk about autoregulation in general, but I want to talk about a variety of other different types of autoregulation that occur. And indeed, the graph that I've just previously shown you is actually demonstrating pressure autoregulation more than anything else. So in pressure regulation, as I've said, there are changes in the cerebral perfusion pressure that are followed by changes in the cerebral blood flow that are controlled by regulating the diameter of the blood vessels themselves. This is the limits of this pressure autoregulation is about between 40 to 150 millimeters of mercury of cerebral perfusion pressure. And then beyond these limits, the vessel caliber can't be used as a method of controlling blood flow, and then the blood flow will either increase or decrease at high pressures or at low pressures, depending on the circumstances. Now, one other autoregulation method that most people don't actually know about or consider is the response to viscosity. The cerebral blood flow can actually vary with the viscosity of the blood. Viscosity of the blood can be changed by natural factors such as dehydration, or by unnatural factors such as administering things like osmotic agents. So, for example, when you increase the viscosity of the blood, you necessarily, all things else being held constant, cause an increase in cerebral vascular resistance. This cerebral vascular resistance decreases the blood flow, and so the blood vessel dilates in order to decrease vascular resistance by increasing the diameter and maintaining a constant cerebral blood flow. So the goal with autoregulation is to maintain constant cerebral blood flow. Now, if you consider the opposite circumstance, where somebody is giving say mannitol, and it decreases the viscosity of the blood. By decreasing the viscosity of the blood, all things being equal, vascular resistance goes down. And by decreasing vascular resistance, you suddenly get an increase in cerebral blood flow, and as a result, the arterioles can then constrict a little bit in order to decrease the sudden increase in blood flow, and so you can get a constant cerebral blood flow at a smaller total blood volume inside the brain. So, what is the underlying cause or mechanism for autoregulation in all of these three cases is probably all sharing a very similar mechanism, and it's probably related to the endothelium. There have been experiments where removing the endothelial layer, inactivating it, causes a loss of responsiveness of the vessel to stimulation such as from vasoconstrictors such as norepinephrine and phenylephrine. So in those circumstances where the endothelium's been removed or inactivated, when you then rapidly increase the transmural pressure, where you would normally see a vasoconstriction that occurs as a result because of autoregulation, you act these cases without endothelium, you see a loss of that ability to autoregulate. And it's believed that the endothelium derived contracting factors are probably thromboxane A2 and endothelium, which are the two most common endothelium contracting factors in the body. Now, you probably noticed that I didn't say anything about carbon dioxide, which is commonly used as a method of controlling cerebral blood flow in the acute situation. And we're going to spend a bit more time talking about that because I think it's important that this concept is made very clear to you and that you understand this. It is true that there are changes in vascular size and changes in cerebral blood flow in response to changes in the arterial CO2 concentration. And this is what we refer to commonly as CO2 reactivity. And you do actually see changes in cerebral blood flow of about 2 to 3% for each millimeter of mercury of CO2 changes between 20 to 60 millimeters of mercury. So within the range of 20 to 60 millimeters of mercury of CO2, you'll see reactivity, and it's not insignificant. I mean, 3 to 3% of cerebral blood flow for each millimeter of mercury can represent a fair amount of reactivity if somebody has extremes of elevations or decreases in their carbon dioxide. And as a general rule, and as you should be well familiar with, hypercarbia causes vasodilation and a higher cerebral blood flow, whereas hypocarbia or respiratory alkalosis results in a vasoconstriction and lowers cerebral blood flow. But you see, the thing is about carbon dioxide is that it's not actually carbon dioxide that the vessels are reacting to. The vessels actually respond to the pH of the blood in the perivascular space. And this responsiveness to the pH actually resets itself within a very short period of time. Usually within 6 hours, if a vessel is constricted or dilated in response to a pH, even if that pH is held constant, the vessel will reset itself back to its baseline. And the other thing that you need to appreciate is that unlike the other methods of autoregulation, which maintain a constant blood flow, in this case, when there is a change in blood flow that then has to be compensated for by the actual oxygen delivery that's occurring at the cellular level. So the AVDO2 actually changes when you change the vessel diameter due to the changes in the pH of the perivascular space. And it does, this is because it's maintaining a constant delivery of substrates that's actually required by metabolism. And so you can see that there's a real danger that if you don't maintain a significant amount of flow, or if you cause hypoxia at a time when extraction ratio is going up, you can actually cause a significant amount of ischemia. So this means that if there's a low CO2, this causes vasoconstriction, and as a result, the AVDO2 increases in order to compensate for the fall in delivery that's occurring because of the vasoconstriction. Now this is, again, as I want to emphasize, different from the other forms of autoregulation, metabolic, pressure, and viscosity autoregulation, where in those circumstances a constant AVDO2 is being maintained in those circumstances and not in carbon dioxide, or changes to pH in the blood rather. So now we should get into some of the nuts and bolts, if you will, of different types of brain injuries that can occur. And to start off with, we'll talk about the primary brain injury. So these are the types of injuries that occur right away. Bullet hits the bone, dashboard hits the skull. This is the injury that occurs first. And so these are the ones that people usually present with, and with the exception of changes in public health policies, are not preventable. Now, the first injury that you should be familiar with is the epidural hematoma. It's a fairly obvious injury, and it's the one that is most famously referred to as the walk and die type of brain injury. This is usually caused by laceration of the middle meningeal artery that sits inside the temporal bone, which demonstrates a little bit of a poor design, putting a fairly important artery running along the thinnest bone in the skull, which the skull itself, actually a very well designed protector for the brain, formed by two very dense bone layers with a very thin, small middle portion to give it a little bit of extra light weight, yet still maintaining strength. The epidural hematoma will expand rapidly initially, causes a lot of pressure, and as you can see in this picture, it has a concave appearance. Now, as I've referred to these as the walk-in dies, these are the people who, approximately a third of the people who present with this type of injury will initially be conscious at the scene, and then as the hematoma accumulates in and starts to cause pressure on the reticular activating system, the thalamus, and the other cerebral content, will then cause them to have a decreased level of consciousness. Now, another 33% of the people will actually present to hospital with this epidural hematoma but with no loss of consciousness, so you can't use loss of consciousness as a marker of whether or not they have an epidural hematoma. And then another 33% of people will actually will have such a significant injury from their epidural, they'll actually be unconscious at the scene as well. The amount of force necessary in order to cause this is strictly limited to the force required to break the temporal bone. And so in relatively speaking, this is actually an injury that doesn't have as much force transmitted to the brain, and ultimately results in better outcomes for this population if you can identify the epidural quickly enough and get them to the operating room to decompress them and evacuate the hematoma. The amount of damage to other structures and force vectors transmitted across the cerebrum to other structures is actually substantially less than in other injuries. Now contrast that with the subdural hematoma, which is much less commonly seen in younger people, but much more commonly seen in older people. And this is because the injury occurs as a result of mostly due from tears and injury to bridging vessels and venous blood that is going from the dura to the brain itself. These people can present with a decreased level of consciousness, or they can actually be completely completely insensitive of their subdural. It's not uncommon for elderly patients to fall and hit their head, have a subdural, and because they've had no other injury to their brain, actually have may not even notice that they've got an injury until they present to the hospital, a couple of weeks later with this persistent problem of headaches or memory loss or some other changes, and then a CT scan is done, which demonstrates that the subdural is actually there and it's actually become more of a chronic hematoma. Now, the major problem with the subdural hematoma is, first off, there may not be as obvious as this picture indicates, where it's a very large convex hematoma is causing a lot of midline shift. Sometimes it can be very subtle, and it's easy to miss if your settings on your CT scanner, if your windows are not set appropriately to detect the subdural, because in the acute phase, the subdural blood can have a very similar density to the bone. And it can be thin enough that you may miss it. So you got to look very closely for it. The second reason why a subdural is a problem is not because of the injury, not because of the blood itself. It may not be causing any significant problems, but it's the injury to the rest of the brain that is the major problem. Because of these types of injuries require a higher amount of force to occur, and this force is transmitted and causes injury to a larger portion of the brain. So in addition to the subdural hematoma, there is usually contusion and other injury to the deeper structures inside the brain. One way in which you can actually tell whether somebody's got a significant amount of edema from the intracerebral component of their injury is to look at the amount of midline shift that's occurring. And if you measure the amount of midline shifts occurring and it's more than the thickness of the subdural hematoma, then that's actually the result, that the midline shift is in part being caused by cerebral edema and not just by the subdural hematoma. This is one reason why neurosurgeons may elect not to operate on somebody for what looks like should be something relatively simple to take out. It's a fairly large clot of blood, a quick craniotomy, and the blood should come out. It's not so much the blood that's the problem, it's the injury to the rest of the brain that is giving the neurosurgeon pause, because the injury to the rest of the brain is ultimately what's going to decide on that person's final outcome. And people who have had significant trauma, usually involving usually motor vehicle injuries or other high velocity accidents, can also present, in addition to these other injuries, can also present with a traumatic subarachnoid hemorrhage. They may be subtle, and as you can see in this image, they're not as easily seen. They may be just present in some of the sulci, and they're not and in the basal cistern, and so not as necessarily as obvious. But it should not be missed because they are an indication of the severity of the trauma. The injury, as I said, again, is usually related to from higher velocity types of injuries. So, because it involves tearing of deep matter, of deep vessels in the deep tissues, is an indication of the high energy nature of the injury itself. Next is the intracerebral hematoma or contusion. These are essentially bruises inside the brain. They're again, usually they're seen in a little bit younger people and may have an associated subdural hematoma component to it. Don't require as much energy to cause an injury. So a guy goes into a bar, doesn't mind his own business, gets a punch and takes a fall, can end up with a significant cerebral contusion, with even a bit of a hematoma, intracerebral hematoma as well. These are injuries that, even of themselves, are not may cause a decreased level of consciousness. Usually, do not necessarily have to cause a complete coma. but they can be problematic and need to be closely watched over, usually in some form of a monitored environment, because they can blossom over the next couple of days. So a consortium of contusion and bruising can cause, as the dead tissue starts to liquefy, can actually have blood vessels that pop open, resulting in a blossoming of the hemorrhage that can even cause significant midline shift and increased intracranial pressures. Lastly, the final form of primary injury that you need to understand is called the diffuse axonal injury. Now, this type of injury is different than the other ones that we've talked about. The other ones we've talked about usually result in some form of high energy or direct energy directly onto the brain, the skull itself. Something has happened, a fall, brain has hit the ground, fist or baseball bat has hit the skull. Something high velocity, high energy has struck the brain or the skull directly. The diffuse axonal injury is a different type of injury. This is a rotational shear stress injury that occurs. It occurs when the brain is rapidly moved forward and backwards, and sometimes associated with coup-contre-coup types of injuries. This is caused by the amount of force necessary to rapidly accelerate and decelerate the brain, causing shear across axons that are starting in the cerebral cortex and running down into the brainstem. And as you can imagine, much like if you imagine the brain as a stalk of celery, that stem of celery, stalk of cauliflower, rather. If you imagine that stem is stuck at the fulcrum, which is your shoulders, and then is rapidly flapped forward and backwards, you'll see that the stem of the cauliflower will start to tear because of the rotational forces that are being applied to it. The diffuse axonal injury is not well seen on a CT scan, and sometimes the only indication that the person has an injury is to see small punctate hemorrhages in the white matter. The injury itself is occurring to the axons. However, because blood vessels are running alongside the axons, they are exposed to the same forces, and small vessels can bleed if they're exposed to enough of a shear force. So you can see these small hemorrhages, and your initial suspicion will be, the patient can't be that bad. I mean, they don't have any major bleeding, but in fact, they may be completely comatose and have like a type of CT scan that you see in this image, where there's just very small punctate hemorrhages around the lateral ventricles that are subtle, and then over 6 hours may start to blossom a little bit, but don't really look like they're that much of a problem. This bleeding in and of itself is not a problem. It's not something you treat, but it's an indication of the severity of the injury. So now, what can we can't do much other than encouraging people to wear seatbelts, not go to bars, or if they go to bars, to mind their own business. We can't do much to prevent those primary brain injuries. But secondary brain injuries are important, and this is something that we can do something about. Now, secondary brain injuries, primarily, when we talk about them, we usually are also concerned mostly about changes in intracranial pressure. By definition, intracranial pressure is the cerebral spinal fluid pressure. Now, there are four parameters that describe the dynamic and the static CSF pressure. One, the rate of CSF production. Number two, variable compliance given by the relationship of the CSF pressure to volume curve. Number three, the outflow resistance, so through the ventricular system. And four, the intradural sinus pressure, so the resistance of the venous system contributes to this. The Monroe-Kelly doctrine is fairly easy to understand. It's states that the total volume of the intracranial contents, the cerebral blood volume, the CSF, and the brain, has to be constant. It's not rocket science after all, it's just brain surgery. The skull is a fixed space, and so you have three things in there normally, and therefore they have to all equal the size of the cranial vault contained within. If you increase any one of these three components, it has to be accompanied by a decrease of equal portions of one of the other components, or else you get an increase in the ICP. This is, again, not rocket science. It's just brain surgery. Now, as long as you can maintain these volume compensations, as long as you can get CSF out or you can cause vasoconstriction, you won't get any change in your ICP. And we normally maintain a normal ICP of around 8 to 10 millimeters of mercury. However, you get to a certain point and the buffering capacity becomes exhausted, and then there becomes an exponential increase in pressure with any further volume addition. There are 5 ways in which intracranial volume can increase. It can be through the CSF system, by increasing the cerebral blood volume, by causing blood-brain barrier damage that causes associated edema, both vasogenic edema, neurotoxic edema, and ischemic edema. The CSF components, which is the CSF resistance to outflow and absorption, only actually account for about 1/3 of the ICP elevations. And as you can see in this curve, which you again have likely been exposed to at some point in time, as you increase the intracranial volume over time, or try to increase the intracranial volume with things, there's an incremental increase in the ICP after you get beyond a certain level and the compliance of the system starts to go down dramatically. And ICP will then start rising rapidly with any further change in the intracranial volume. Now, this may look like a bad thing, but it actually plays both ways. So in the case where if you have somebody with elevated ICPs, one treatment option is to remove some CSF, and sometimes as little as a couple of cc's may be all that is necessary of fluid out in order to bring the ICP back down to a safer zone. Now, the blood component of this is a bit more of a challenge. As we've talked about earlier, the cerebral blood flow is determined by the total diameter of the cerebral vascular bed. And about 20 milliliters of blood, which is about 1/3 of the total cerebral blood volume, is located in the cerebral vascular resistance vessels. Now, these are the vessels that are regulating, that are controlled by autoregulation. And so these are the vessels that can increase and decrease in size. However, 2/3 of the blood volume sits in the venous system, which has very little control. There's no feedback system to decrease the size of the venous system. And so again, although you get most of your autoregulation and diameter variations taking place in these blood vessels, you don't necessarily get as much of a impact on your total blood volume from their diameter. But again, in cases of increased ICP, because of the compliance curve, you can make small changes in the vessel diameter and it can have a big impact on the total intracranial pressure. Now, it's one thing to talk about changes in ICP, and for basic understanding of brain injury, that is usually sufficient. But I think it is important that you have a better understanding of the response to the injury that occurs in the cerebral circulation and the metabolism to help you appreciate the overall consequences of injury to acute brain injury. As a result of any injury, the cerebral metabolism can be dramatically disturbed. Now, normally, as we've said, the cerebral metabolic rate of oxygen is about 3.2 milliliters of oxygen per 100 grams of brain per minute. But when somebody's comatose, you can dramatically reduce their oxygen requirements to between 1.2 to 2.3 milliliters of oxygen per 100 grams of brain per minute. At the same time, there are problems with ATP generation from oxidative phosphorylation, either because of low blood supply, low cerebral flow, or hypoxia, or by direct dysfunctional mitochondria. So mitochondrial failure and an inability to actually utilize oxygen can be a significant problem in the generation of ATP in the brain as a result of injury. As well, there's a significant amount of cerebral acidosis that occurs after a severe brain injury, and this acidosis shifts the oxygen dissociation curve to the right so that oxygen can be more completely extracted from hemoglobin. This is therefore defensive in maintaining oxygen, and it as the acidosis also optimizes the pH for glycolysis and can cause vasodilation of the blood vessels to try to maximize the available blood flow in order to ensure that a sufficient amount of glucose and oxygen is getting to the brain. However, as you can well imagine, that in the presence of a high lactate or high anaerobic metabolism, the ability of the tissue to recover because of the acidotic environment is usually much poorer, and the functional outcome is much worse as a result. Now, there's also a significant disturbances in blood flow that occurs as a result of injury. And as we've seen in that previous graph on autoregulation, the brain becomes much more vulnerable to ischemia after a head injury. The loss of the ability to autoregulate, in addition to shifting of the actual autoregulatory curve, makes the ischemic threshold occur at a much higher perfusion pressure than would normally be occurring in normal brain. There are a variety of different metabolic and biochemical derangements that occur, usually involving excitatory neurotransmitters such as glutamine, which increase the insult and can cause a lethal threshold to be reached that causes the brain to be much more vulnerable to further ischemic damage as a result of the ischemia. So it becomes a bit of a vicious cycle. In areas of declining cerebral blood flow, whether that's because of the loss of pressure, autoregulation, or hypotension itself, there is initially some protection that the brain can initiate by protect itself from the ischemia and maintain its oxygen and glucose supply by increasing the extraction of oxygen and glucose from the blood flow. So this causes an increase in the arteriovenous oxygen delivery difference. So as we bringing forward what we had talked about earlier about the differences in autoregulation and CO2 reactivity and its impact on the AVDO2. However, as you can well imagine, in the environment of an injured brain, its ability to extract may be deficient because of the inability of the mitochondria to actually efficiently utilize the oxygen, and there may not be a sufficient blood supply to begin with. And so there's only a certain amount of bang out of your buck you can get by increasing your AV extraction ratio. There's also a loss of and changes to metabolic autoregulation. Generally, when the brain is injured, much like many other tissues, there's an increase in the blood flow. Now, in the past, this was assumed to be what was called luxury perfusion. It was just increased perfusion for no actual real need because, in fact, normal cerebral metabolism was depressed, and this extra flow was actually not really necessary. However, remember, the cerebral blood flow is actually tightly coupled to the cerebral metabolic rate for glucose. And so when you see an increase in cerebral blood flow, it may not actually necessarily just be luxury flow, but it may actually, in fact, be due to an increased demand for oxygen because of increased oxygen turnover. Um, and for hyperglycolysis, so increasingly using CO2 or glucose in order to produce ATP. If you have a deficient electron transport chain, if you're going to generate ATP, you're going to need to consume more glucose in order to generate that ATP if you can't use the mitochondrial electron transport system. So you would have to necessarily then increase your cerebral blood flow in order to get that extra glucose. And that means that this increase in blood flow is not luxury perfusion. It's actually necessary perfusion, and decreasing its perfusion artificially or decreasing the amount of blood flow artificially actually causes further harm. Now, pressure autoregulation also can be disturbed in injury and cause problems with cerebral blood flow. When this occurs, autoregulation is usually a temporary, or loss of autoregulation rather, is usually temporarily gone, and usually will recover within a few days without any real impact on the overall patient outcome. The exact mechanism is not entirely understood, but it's believed that it may be related to changes in the brainstem and damage to brainstem autoregulatory centers, causing the loss of the ability to autoregulate in response to changes in cerebral pressure. Endothelial damage may also occur, particularly involving the generation of reactive oxygen species and direct injury to the endothelium, and then this would then have a necessary impact on the pressure ability of those vessels to respond to changes in pressure, as we've talked about previously. Now, viscosity, as I've alluded to earlier, is probably one of the major reasons why mannitol works the way it does. It doesn't, in fact, necessarily cause a osmotic diuresis. While certainly it does do that, when somebody is given a bolus of mannitol, we frequently will see a decrease in their ICP rapidly before we see any change in their overall total body water or their urine output. So viscosity has to be at play here, and mannitol decreases the viscosity of blood. Now, as I've said, when the viscosity goes down, when mannitol has been administered, cerebral blood flow increases in response. And in the areas of the brain where you still have pressure autoregulation, as long as those areas are still intact, this lower viscosity causes this increase in blood flow, which then permits the blood vessels to constrict a bit to reduce the total blood volume and decreases the net total blood volume of the inside the entire cranium. Now, as I've indicated earlier, because these autoregulation vessels are all on the arterial side, and it only forms 1/3 of the total blood volume in the brain. Because of the compliance curve, you can still get an awful lot of bang for your buck. And so this change in viscosity can have a significant impact on the ICP in the really tight brain. Now, finally, the carbon dioxide reactivity can be disturbed by a brain injury. However, for the most part, CO2 reactivity is usually preserved even in severe head injuries. When people have, and in patients where there is an actual loss of CO2 reactivity, they are probably so severely injured that they're not going to survive, or they're left with severe neurological defects. So the ability to respond to CO2 can be used as a marker of the severity of the underlying brain injury. How the pathological mechanisms for the changes in CO2 reactivity are not really understood, and as with most things, when you don't know what's causing it, blame the free radicals. They're probably to blame. Now I want to go over again the cerebral blood flow, blood volume, arteriovenous difference in oxygen, and autoregulation. Again, just to make sure that this point is clear, because this is important. The cerebral blood flow is influenced by the vascular diameter, the viscosity of the blood, and the cerebral perfusion pressure, whereas the cerebral blood volume is determined by the vascular diameter only. Now, any decrease in cerebral metabolism results in a coupled decrease in cerebral blood flow. This caused by vasoconstriction as a result of metabolic autoregulation. When you have cerebral blood volume decreases due to reduced vascular diameter, the AVDO2 remains constant because the cerebral blood flow is tuned to the metabolic demand. The metabolic autoregulation is occurring, and is with decreased metabolic demand, you cause vasoconstriction, and the extraction ratio does not change. Now, any reduction in cerebral perfusion pressure leads to a compensatory vasodilation when there's an intact autoregulation. The cerebral blood flow remains the same, but cerebral blood volume increases because of the larger vascular diameter. But again, metabolism and cerebral blood flow, because they're matched, maintain constant AVDO2. But under certain circumstances, cerebral perfusion pressure decreases because of defective autoregulation. Now, in this scenario, cerebral blood flow and cerebral blood volume follow the decrease in perfusion pressure passively, just like we saw in that curve where there's just a single straight line of perfusion pressure to blood flow. There's a passive change. Any change in pressure causes a decrease in cerebral blood flow. Now, as a result of this, the AVDO2 increases because the cerebral blood flow is now no longer adequate to maintain the metabolic, to meet the demands of the brain's metabolism. So an increase in the AVDO2 is, so an increase in the extraction ratio occurs is an indication of an injury to the brain and a loss of the autoregulation. So you recall earlier I talked about hyperventilation or CO2 reactivity causing alterations in the AVDO2 and indicated that that was probably a bad thing. So to get into to be absolutely clear about this fact, so in the circumstances of a respiratory alkalosis, because of the hyperventilation, you get a reduction in the cerebral blood volume because of vasoconstriction. This vasoconstriction causes a decrease in cerebral blood flow. But remember, the blood flow is being set by other autoregulatory mechanisms, such as the metabolic demand. And if you're not meeting the metabolic demands of the brain by artificially constricting the blood vessels, then necessarily the oxygen extraction has to go up. Because now the cerebral blood flow is insufficient to meet this demand. Therefore, hyperventilation causes a fall of ICP, but at the expense of ischemia, which probably is not a good idea. So finally, I want to go right back to the cellular level and talk about the individual neuronal cellular response to injury. Because understanding the spectrum of things that happen when the brain has been injured will help give you a sense of what therapies are being developed to try to mitigate injury and secondary injury, and why some of the things we do in neurocritical care is so important. Now, calcium itself can cause a significant amount of secondary injury or be responsible for a significant amount of secondary injury. The trauma causes calcium to enter through the voltage-gated channels, especially those that are responsible for the release of response to glutamate. Generation and release of excess excitatory neurotransmitters actually leads to further cell death because it increases sodium and chloride influx, which causes further swelling, and it also increased intracellular calcium. This intracellular calcium then has a direct injury to the cell membrane because it activates phospholipid A and phospholipid C second messenger pathways. As well, there are fatty acid changes that lead to the breakdown of the blood-brain barrier. It causes further cerebral edema and generates arachidonic acid byproducts, which have further direct impacts on the cerebral blood flow. Finally, reactive oxygen species are released by the mitochondria because of calcium-mediated disruption of the electron transport chain. These reactive oxygen species cause direct damage to the cell membranes, as well as you know, and also cause DNA strand breaks, which impair the ability of the cell to repair itself. These increases in intracellular calcium also can activate the Calpain pathways. Now, Calpain is a non-lysosomal cysteine protease which is then activated in the presence of elevated intracellular calcium levels. When calpains are activated, it causes direct proteolysis of cytoskeletal proteins, as well as neurofilament proteins and tubulin, which causes direct injury and damage to the cytoskeleton of the cell. These calpains then are probably responsible for contributing to the initial processes that ultimately lead to cell death. As I've insinuated earlier, the mitochondria in the face of injury can also become damaged and can become dysfunctional. The presence of calcium in the mitochondria can cause problems with the ability of the electron transport chain to operate, and this can then cause the inability to generate a sufficient amount of ATP for all of its metabolic needs, and also the generation of an excessive amount of electron transport, reactive oxygen species, which then cause further damage to other parts of the cell. When the mitochondria is failing, it leads to cell death, and is primarily through a loss of the ability to generate energy and through the oxidative damages caused by the reactive oxygen species. The calcium also causes an increased permeability of the inner membrane, which leads to rupture of the mitochondria itself, further impairing the cell's ability to produce its own energy. Calcium just continues to cause problems, and increased intracellular calcium activates protein kinase C, as well as calmodulin kinase, which are responsible for phosphorylating transcription factors. If these transcription factors induce the production of Jun and Phos RNA sequences, this can lead to cell death as part of the apoptotic pathways. So now, what happens in the circumstances of diffuse or traumatic axonal injury? Many of the same processes are in play, but in the cases, because of the shear stresses that the axons are being exposed to, the majority of the axons undergo progressive axonomy with interaxial perturbations, changes to the cytoskeleton, and then impaired transport and axonal disconnection. And as you can imagine, when you start to disconnect the axons or impair their ability to transport substrates, you impair the ability of that axon to repair itself. Now, normally in the cases of mild injury, there's an increase in axonema that permeability goes up, and there's an increase in calcium. This causes further injury by cytoskeleton misalignments and impaired axonal transport. Now take it to a more extreme case where moderate or severe injury leads to massive increases in axolemma permeability, much higher levels of calcium influx, and then we start to activate all these other pathways like Calpain. Then the neurofilaments in those circumstances start to compact. You start to lose your microtubules, the mitochondria swells, and cytochrome C becomes activated. This then leads down a common final pathway for injury where there's axonal swelling, disconnection, and then eventual Wallintron degeneration. So the axon is then lost. This takes time to occur, and this delay in effect, even though is a direct result of the injury that occurred at the time of the incident, but because of the delay in these pathways forms suggest that there may actually be a window of opportunity for us to act in order to try and prevent the damage from getting any worse. But when we fail to do that, then the cells will die, and apoptotic cell death occurs both acutely and chronically, and this is triggered by the activation of a variety of different cysteine proteases, capsases 3, 8, and 9. Now, capsase 3 activity is increased in the cortex within 6 hours, will normally peak by 24 hours, but can persist for as long as 72 hours. So again, this represents the possibility of an area where we can actually decrease the total number of cells that go on to apoptosis. There is the possibility of regeneration. It is limited in many respects, but you can see some neurons do eventually find a way to regenerate. The attempts at regeneration get shut down in part from intrinsic properties of the neuron, when the neuron is clearly just not going to be able to regenerate, or because of external factors that affect the axonal outgrowth. These are, again, things that we do that may actually have an impact on enhancing regeneration. But once scar formation occurs around the injury sites and the presence of myelin surrounding the axons are probably most responsible for determining when regeneration occurs or does not occur. So the million-dollar question is, what can we do about it? Well, as I've said before, there's a wide variety of research across many different areas to try to find ways to prevent or to mitigate secondary injury at the cellular level. However, the key things that we must do initially and over the course of their critical care is to make sure we do everything we can to avoid any further secondary injury to the brain. First off, this means you absolutely must defend against hypoxia and hypotension. You can't, and you cannot let them get hypoxic. They need that oxygen, and you have to make sure that they're getting an adequate supply of it. And as well, they need to have a blood pressure because they don't have the ability to auto-regulate anymore, and they could become exquisitely sensitive to changes in blood pressure and have significant impact on their cerebral blood flow as a result. When we talk about preventing secondary injuries, we're generally also talking about management of the increased intracranial pressure that occurs as a result of all of these injuries. Now, there's medical and surgical management for increases in ICP. Surgically, you can manage them by putting a drain in. So the most common device we put in for both monitoring the intercerebral pressures and also for draining excess CSF is the external ventricular drain. Now, there are a variety of monitors on the market that can monitor intracranial pressure, but the external ventricular drain has the ability to not only measure the pressure directly, but also has the ability to drain CSF and actually treat the increase in ICP. There are a number of different technical reasons why you might not be able to get a drain in, and this is a procedure that is done strictly by neurosurgeons, as they're the ones who are going to have to manage the consequences of any complications if by inserting the drains. So ideally, an external drain a ventricular drain is put in, but as an option, we may choose to put in something called a subarachnoid bolt to measure ICP, but it lacks the ability to measure to actually drain CSF, so you lose that ability. On the left, you can see the setup we have for an external ventricular drain, or an EVD, and I sincerely hope is the CSF of somebody you'll never have to see, somebody who's got what almost looks like frank blood sitting in their this being drained out of their ventricle. The other method we can surgically manage the ICP is by doing a decompressive craniectomy. Now, the French, as you can see on the right-hand side of this picture, had a way of opening the skull that was a little bit extreme, and well, probably best when the patient was at autopsy. But nowadays we do the surgeons will do, say, take off a bone flap, usually taking off a portion of the parietal and temporal bone to decompress the side of the brain that's affected. Again, when you have a patient who presents and you're managing in a critical care environment who you think is at risk for developing ICPs, having a conversation with your neurosurgeons early is beneficial to identify under what circumstances they're willing to take the patient for decompression. The philosophy of doing decompression will vary between neurosurgeons. Some are more up on the literature that shows that there is value in doing and benefit in outcomes in doing decompression, and others are a bit more reluctant to proceed with decompression because their fear is that, in a sense, we're only just saving that individual to have a horrible neurological recovery. Now, obviously, the ICP is a indication of severity of injury, and so obviously decompressing them doesn't fix the ICP problem. It just prevents the ICP from causing further damage, but there is obviously still damage that has occurred as a result of that's causing the elevation in the ICP and the swelling. So talk to your surgeons early and frequently keep them up to date on what's going on so that they know and they can plan and anticipate if there's a desire to take the patient to the OR to decompress them. Now, the medical management of increased ICP is usually we approach it in a stepwise manner, starting off with the motherhood and apple pie sort of things that we should all be doing for all of our traumatically brain injured patients in critical care. First and foremost, if their level of consciousness is such that it needs it, you should capture their airway, control it, make sure that you prevent hypoxia and hypotension, as I've said. And you also don't want to let them have fevers because hyperthermia is directly injurious to injured brain. Next, you also would like to make sure that you identify and treat any seizures that are occurring, and the incidence of seizures in subclinical non-convulsive status is actually reasonably high in the traumatically injured patients. So if things are not progressing for the patient, you should consider getting an EEG, or if you have it available, putting a continuous EEG monitor on the patient for the first couple of days after their initial injury. Often it's considered usual to put patients who have had a traumatic brain injury on some form of seizure prophylaxis using either, most commonly, Dilantin, but occasionally Keppra. As you're managing the patient, and usually you will have some form of an ICP monitor in place to go along with this and to help you. The indication for insertion of an ICP monitor is an GCS less than 8 in any patient with a traumatic brain injury. So again, talk to your neurosurgeons frequently about whether or not a drain is right for you. Your goal is to keep the ICPs less than 20 as a bare minimum, and at best also keep the CPPs, or the cerebral perfusion pressure, more than 65. Ideally over 70 is probably better. Now, different units have different philosophies about ICPs. In many sites, or rather the vast majority of sites I've worked in, the controlling the ICP is the primary focus. So keeping the ICP low is considered the appropriate thing to do. And then by that very nature, you usually are keeping the CPP over 65 or 70. There are some people who ascribe to the cerebral perfusion pressure philosophy and believe that if you just keep the cerebral perfusion pressure up, it really doesn't matter terribly what the ICP is, because you're still maintaining increased blood flow, you're still maintaining cerebral perfusion. Now that was in vogue a while ago, and it seems to be falling out of favor overall, but you will occasionally see it in patients who have chronically elevated ICPs, where we've done everything else we can and their ICPs are still elevated, and this can occur even in patients who've had surgical decompression. Often our only option is to maintain the CPP to maintain perfusion as best we can. Once you start having problems with the ICP, though, usually the next step after that is to start considering adding osmotic agents in addition to sedation to keep them calm, keep their brain from working too hard, and to try and keep their brain oxygen demands as low as possible. The osmotic agents, as I've said, mannitol and 3% saline are the two agents that we use. Again, they have a dual effect, both in the diuretic effects of the mannitol, but also the viscosity changes that occur probably also have a direct impact on cerebral blood flow. We normally will give acutely, you give 1 gram per kilogram of mannitol for acute emergencies. But when you're starting, when the patient's in the unit, we usually will give them 0.25 milligrams per kilogram, or often we'll just round it up or down to 250 or 200 milliliters of mannitol, and we'll give it around the clock every 4 to 8 hours, as depending on how bad the ICPs are. In addition to giving the mannitol, you should also be following closely the serum sodium and the serum osmolality, because once the serum osmolality is over 320, or the serum sodium is over 155, you've reached the limit of therapy for your osmotic agents. Now, if you're failing that, if you're continuing to have problems with ICP, then you can start, if you haven't already put them on a continuous sedation agent such as propofol. This would be a time where you should be doing that. If they're already on something for continuous sedation, you can try augmenting with narcotics and a benzodiazepine, or if failing that, you can also consider neuromuscular blockade as a bit of a pharmacological Hail Mary. The final step in the management of ICPs is the extreme, and this is where we start actually aggressively cooling people or putting them into a barbiturate coma. Barbiturates will cause isoelectric EEG, so it's the ultimate way of making sure that there's absolutely no metabolic demand in the brain, is to actually turn the brain off with a barbiturate infusion. Hypothermia has been in the past considered a therapy of choice. Generally now not as efficacious as believed. We will occasionally try it again as a bit of a Hail Mary. However, just like at the very beginning, you want to make sure at all times that you're preventing seizures, or preventing fevers rather, and being aggressive about fever control at all points in time. And then failing, if they're really failing therapies, you can consider taking their temperature down even lower, although the evidence for that is not at all very good. So finally, I just want to again go over the issue of hyperventilation. I think it's important that you understand that hyperventilation is harmful to patients. You cause by overriding their ability to auto-regulate, by taking advantage of the CO2 reactivity, you cause vasoconstriction. And when you cause vasoconstriction, you increase oxygen extraction. And in an area where there's inadequate oxygen delivery, you are causing ischemia. You are causing harm. So it is never a good idea to just prophylactically hyperventilate somebody. You are doing harm to that patient in the short term, and you are doing harm to them in the long term. Because as I've said it before, the vascular reactivity goes away and resets itself once you start after about 6 hours. So if you lighten up on the CO2, if you let the CO2 creep up again after you've been hyperventilating them, you will cause a relative vasodilation, you will increase blood volume, you will increase ICP, you will cause further harm. There is only one acceptable circumstance where hyperventilation is what you should do, and that's when they blow their pupil in the OR on their way to the operating room. Hyperventilate them there, never hyperventilate them anywhere else. And there's no such thing as, just to be on the safe side, let's blow their CO2 down a little bit. That's dangerous, it's bad, do not do it, and do not let your respiratory therapist do it. It is a dumb, dangerous, bad idea. I cannot emphasize how much you should not do that. And that is it. This was a longer talk for sure, and if you've stuck in with it, I appreciate you listening. And if you have any questions or comments, please feel free to either email me or message me, or just put them in the comment section below with the video. And again, thank you very much for listening.